Hi, Kuldip.
Hello, how are you?
Welcome. We're delighted that you could join us today.
Thank
I'm
you.
just seeing everybody joining, so if you will just bear with us, I'll see, because we've got a minute left before past. Would you like me to do an introduction of your background and things
That
to
would be
everybody?
fine. Yes.
Yeah,
Yeah.
great. Okay, I think there's people joining now.
Yeah. Yeah. Can I just check? Is it just midwives or?
It's a number of people from across the organisation who are interested in the subject. So you'll see we've got a number of people from surgery. We've got our chief executives joined. We've got people in corporate services who support the teams with improvement. So a number of people from across the organisation, because it's an interesting topic.
Well, it is. It is.
Yes. So in the spirit of starting on time, welcome, Kuldip, for coming along today to give us this talk. And just for everyone who's joined us, thank you so much for taking time out. I'll just give you a bit of background into Kuldip. She's had over 40 years engagement in midwifery, spanning education, research and practice. After working as a clinical midwife, she moved into midwifery education in 1981. Currently, she's a visiting associate professor at Leeds University and a maternity investigator with healthcare safety investigation branch. Extensive experience of providing and delivering education within an interprofessional environment, coupled with in-depth knowledge and understanding of policy, practice, and regulation underpinning maternity services. Her principal interests are around policy, practice, health inequalities, midwifery education and research, and practice, quality and safety, and evidence-based practice for women's experience of maternity services. Her research and publications include presentations of papers at national and international conferences, which have covered areas in education and NHS health services. Further to over 10 years in NHS public appointments as a non-exec director for a local health authority in Leeds PCT and a chair at Leeds West PCT of the NHS Trust. She was a served as a member of the Nursing and Midwifery Council and served on Prime Minister's Commission. And in 2009, your work was absolutely recognised in being given a Queen's Honours, listed as an awarding of an OBE. And earlier this year, you were appointed as Deputy Lieutenant for West Yorkshire County. So we're absolutely privileged to have you here with us today. So if I could just give people some of the etiquette for the webinar, if you could all turn your cameras off, please, and put your mics off so that we can have more of the screen. And I'll hand over to you. So thank you very much.
Thank you. I will just have a. All right. Well, thank you very much for the introduction. And I guess two things for me that I just wanted to focus on is clearly I've had a wealth of experience within NHS as a midwife and then as a practicing educator and a researcher. And some of the areas that I've researched have been around women from Black and minority ethnic communities. And so I feel privileged to come and share with you some of my early findings of research, but certainly contextualized in current evidence. And so thank you very much. And it's very difficult to present like this because when I'm in a presentation mode, you probably can't see me, I can't see you, but I'm very much used to certainly around topics like this to have an engagement. So what I might do is speed through some of my slides and leave some questions, time for question and answer, because I think it's great to engage, particularly in topics that are so sensitive. And within this, if I have time, I want to talk about my trajectory You know, having worked in the NHS, education, public sector, steeped in, and what changes I've seen and what's really profoundly upsetting when preparing sessions like this, because it's constantly continue to see, you know, repeatedly the same things despite all that's been done. And I thought, when Kuldip asked me, I did select this topic. The reason is because I thought it aptly fits in with the current Black History Month, you know, ethos, because the theme of this year's Black History Month is time for change, action, not words. Well, when I saw action, not words, it reminded me when I first started on this journey of looking at services for Black women, because NAHAT at that time in 1988 produced this report, Action, Not Words, Strategy for Change. And I thought, wow, you know, so many years on, we go back to the same things, and I can understand why that is so. And other thing that I thought this was a really good topic to fit in with this month is because the theme focuses on you know, double burden that Black people carry. The double whammy comes from the experience of racism and discrimination, and then they're expected to fix it. So I just thought this was just great. I'm hoping to talk about what is intended in British maternity services. Although I'm using the term British maternity services, those colleagues who are on this webinar who aren't midwives can just say British Health Services, because some of the drivers and policy recommendations are about enhancing and improving and promoting health services. Then I want to talk what does happen, you know, what is the reality? And the third section is about, you know, action, not words, you know, what needs to be done. The evidence that I've sort of drawn upon are clearly this year there's been publication of birth rights, which you know, human rights research that looked at systematic racism, and it's very powerful reading. The second research that I draw upon is by Peter and Wheeler, involved with you know, co-founders of 5 Times More, which is Black Maternity Services Survey. Again, a wealth of people who've you know, responded to that survey and their analysis. And then I've drawn upon 2 pieces of work from myself. One was a collaboration between Universities of Nottingham and University of Leeds, where Professor Higginbottoms led this project in which I was a co-applicant, and it were NIHR funded project. And then, you know, we looked at access and interventions to improve maternity services for immigrant women. This was a narrative synthesis. And then I draw also upon some of my research, which I undertook for my PhD studies, which looks at Pakistani women. And I know that we're talking about Black women, but I think we can't negate some of the experiences of other women from Asian and migrant backgrounds who experience very, very similar issues. So I put this on just to remind us that really it is every woman's right to best and safe maternity care during pregnancy and childbirth. And I don't think anybody would disagree with me on that. We know that every pregnant woman and her family want a positive and safe birth experience. every member of staff working in maternity services and in wider multidisciplinary teams want that. They strive to provide safe and high quality care. And in most cases, that is what happens. And I've drawn this sort of narrative from Care Quality Commission that published their, their analysis this year, well, in October this month. And they do say that that happens in majority of the cases. And when we look at some of the testimonies of women, they echo that. But when things go wrong, for example, maternal deaths, baby deaths, the consequences for mothers, babies, and their families and wider society are just so devastating. And again, nobody wants this. Clearly, we can see that the context of maternity services and broader health services is about meeting and responding to society's, people's, patients, their families, needs. And I don't want to spend a lot of time on this slide, but this for me capitalizes what NHS strives for: a patient-centered health services, which are high quality, safe and personalized. They focus on quality of experience and quality of outcome. They give service users, women and their families more rights. We can see that in NHS constitution. And they look at empowering, service users, and they're looking at, how people in the society, how women can take control over their health, remain healthy, and prevent becoming ill.
Kuldip, can I just come in there? Are you sharing? We can't see your slides. I'm not sure if you've
can't you?
shared them.
Yes, I have. Oh, my apologies.
That's okay.
How do I? I'll go back. Can you see? Oh, I'm so. I am sharing them. Let me see. That's
it.
Working?
That's it. We've got them now. We've got them now.
All right. Oh, I'm glad. I was just going on and on and.
No, you were. I was fascinated by what you were saying, and then when you said on this slide, I thought, oh, you must be showing slides. So we've got them now.
Can you see this slide then?
Yes, we can now.
All right. So that I'll just quickly. So that were why I thought we fitted this topic fits in Black History Month. And I mean, if you want to, I'll send this set of slides back to you after the session. Outline of the presentation is this. Evidence that I've used is Birthrights, Peter and Wheeler, Higginbottom et al. That's systematic review where I was involved, and my own piece of work. And of course, I've drawn upon other pieces of work as well. This is the picture that I shared with you, just sort of saying that every woman wants the best for, outcome during pregnancy, and so does everybody else involved in childbirth. This is what Care Commission were finding, that this is where we're striving for, and happens in majority of the cases, but there are times when things go wrong. And this slide capitalizes what we strive for. Look for quality and safety, which is at the heart of our service providers. We look at NHS that puts women and their families in the center of services, wraps services around them and empowers them. But for me, key tool who can do this is not just the women themselves and the managers and leaders, but the practitioners. So I think the NHS looks after or strives to look after, should I say, staff, empowering them and leading at frontline level, and looking at clinical stuff, leadership at all levels. But at the right side, I was going on to talk about raising standards, purely in terms of improving experience and outcome for women. And we've seen, late 90s and early 2000, directives which were looking at quality, really matters to people. And it just doesn't matter because of their experience, but it makes sense for businesses like NHS, and it's also, using good public monies as well. So quality is key. And, looking at decision making, putting it right at the clinical level and with clinicians and women, and clearly pioneering NHS. We are, next slide probably won't echo this, but we are an envy of many of the countries in the world because we, give, the best as we can, maternity services. So if I move on to the next slide, okay, this is what NHS strives for. But really, when we look at maternity services, I've just pulled this off from, Care Quality Commission's report, which were published, this month, 21st, this week, should I say, which talks about, that really, when we look at this slide, it's quite concerning that many of maternity services are not meeting, good standard. When we can look at it, at this slide compared to 21, 6% are inadequate, and 45 organizations, require improvement. We look at good, the organizations have reduced compared to last year. And, this about 6% or 4%, 6 organizations that are, accredited as outstanding. I don't particularly want to feature too much on that, but we can see from some of the investigations that are taking place at national level. Ockendon's just published as well. We've got another one in the pipeline, Nottingham maternity services, and we can see that, it is concerning that whilst all this effort is being made at policy level to improve quality and safety in maternity servicing in England, despite this greater national focus, the pace of progress, what Care Commission argues, is too slow. And, and the actions to ensure all women have access to safe, effective, and truly personalized maternity care has not been successfully prioritized, they argue, to reduce risk and help prevent future tragedies from occurring. I think when staff, clinicians strive to give good quality of care, reading analysis like that, listening to what Ockendon's saying is just very disturbing. But what's sad is that some of the themes that are emerging in Ockendon, and certainly in other analyses, they seem to be saying this very same things about, team working, women not being listened to, and so on and so forth. And I guess in this slide, I've tried to put in context how difficult and how emotionally draining it is becoming for the staff, because the demand is outstripping what the NHS can provide. That's due to changes in demographic profiles. We find that the requirements are much more complex. like when I practiced as a midwife back in 1973, 74 time, we didn't see what midwives are seeing like now, women collapsing, women having heart attacks on delivery suites. We didn't see those things. The complexities have increased, and with that, quite rightly, women's expectations have risen. We talk about women. I've seen women in 3 generations. The first generation of women that I cared for were very much compliant. They didn't want to raise issues. They just accepted what was given. The second generation of women started to become more, able to understand and have knowledge of how NHS maternity services work, and they're able to now navigate the system and articulate what their needs are. And their ecology is very different. I see that in my children, and I see how my father used to be. When I used to talk about all this, this, marginalization, this, stereotype discrimination, and do you know what? He used to call me putter, daughter. Look, this country is giving us a lot. We are here just to be quiet and accept it and carry on. And I think I did that. Whereas when, well, I say I did that, but there were areas clearly you can see from what I'm presenting, from my publications, that there were areas that I questioned and I, led on. Which did ruffle feathers, but that's what I did. However, when I see my son and my daughter, who are in their mid to late 30s, they're not accepting this. So you can see why women's expectations, are at the fore as well. I'm very mindful that I don't want to focus too much on this slide, but I think it is important. We need to understand that what is the conduit that's going to look at what the NHS sort of policy is. How can it be translated? And it's the staff, I think, who are the key in terms of doing, achieving this. But I think I just need to pick on this side. The key thing is that we know that the NHS or say wider society is at breaking point, or would say they're like a pressure cooker, or the system's under pressure, because we're experiencing great shortages, extremely worrying midwifery shortages in the labour market. And that is impacting on the structure of the workforce. The skill mix worries me at times, because universities are training midwives. Midwives are being employed, but I think midwives are leaving the profession faster than we can recruit and get midwives in the into the system. In sort of late 90s, there were a worry that people are there at retirement age and they'll be leaving the profession, and we'll have a pitfall and all that, and the recruitment were increasing. However, we're finding midwives aren't leaving because of their age. They're leaving because they can't hack it. They're emotionally drained. There's work like Billy Hunter's, which talks about emotional labor. And midwives' testimonies in that research were just heart-aching. Midwives saying, we give our all during work, and when we come home, I've got nothing to give my family. I think that is just very harrowing. And I know in organizations now, people looking at, or what they say is, we're thinking outside the box and we're creating new roles. We're trying to look at maternity support workers coming and taking some roles. We're looking at employing staff midwives to do some of the work. Sorry, staff nurses, qualified nurses. That's worrying me because nurses are short anyway. So if maternity is going to take them, what's going to happen to nurses? And that takes me, when I hear that, it takes me back to sort of late 80s when that was the model. And then, standards were falling. So then the regulators were saying we have to have qualified staff working in a year. So I think I just can see pendulum swinging backwards and forwards. So little said on this slide. I can come back on it, but just want to say that really when I'm going to talk about women's experiences, we have to keep this in context that NHS is trying to do its best, the system's under pressure. And, there are leadership and management challenges. We cannot recruit high level stuff of managers within the maternity services. And I guess that's the case very much for broader NHS. The demographic changes, not want to labor this too much, but really migration in this century, as we can see, unless obviously the politicians, Rishi Sunak does something different, which I doubt, has been significantly contributing to the UK's overall population growth. And, we are a super diversity country, because, we're taking migrants, and majority of women who are accessing maternity services are transnational migrants, and inevitably this is going to directly impact on maternity care and services. Final stop point here is that UK health services are clearly working towards delivering services which respond appropriate to the health and social care needs of its diverse population. And this can be seen in the earlier slide, which talks about some of the philosophical ideologies and values of the NHS to promote that. This is additional slide. I'm just going to skip on it, but just wanted to sort of say that despite all this that's been done, we see some stark inequalities and inequities in British maternity services, which says that despite all that's been done, women from Black, Asian, minority ethnic communities experience disproportionate inequalities in access and utilization of health services, and migrants are amongst the most deprived members of the UK minority ethnic communities, and women from Black, Asian, minority ethnic communities have poorer experiences of care compared to their white counterparts. In addition, they have higher rates of maternal mortality and morbidity, and which are significant higher than their white counterparts. And we can see that there's been wealth of evidence over time, which is demonstrating that women, from Black and minority ethnic communities experience, more deaths. In this slide, it's showing that the Embrace, which is the inquiry into maternal deaths and morbidity, demonstrate that right from 2019 to 2021, that there's been disproportionate, maternal deaths in women from Black, Asian, and minority communities. Although it's reduced slightly, but it doesn't have much significant impact. It's not significantly reduced in sort of statistical terms. Women in 2019, Black women were 5 times more likely to die compared with the white women. Asian women were 2 times more likely, and women with mixed ethnicities were 3 times more likely. And you can see that in 2021, that the Black women are still at increased risk of dying during childbirth, and Asian women too. Likewise, mixed ethnicity women are also more likely to die. And this devastating picture doesn't stop here. We see similar findings in babies of Black mothers. They're twice as likely to have stillbirths. They are at an increased, nearly half of chance of increasing of neonatal mortality, that's dying within the first 28 days of birth. And likewise, Asian women are more likely to die. And although, we're talking about statistics, just going back, to 2019, but what's upsetting is that these figures were evident back in 1997, when I looked at, for this particular presentation, looking at what was happening over time. In those days, in that time, 97, the publication talked about 20 times more likely to die women from minority groups, but then they looked at all the minority groups together, whereas they can desegregate women now. So it's not just the death rate. We see that the experiences of their encounters with maternity services is not good either. The studies are suggesting that Black women report both positive and negative experiences. However, negative experiences far outweigh those in which women express satisfaction with their care. The negative experiences would fit within the overarching framework of 3 interrelated constructs centered around healthcare professionals. And this is what 5 times more report talks about. They talk about attitudes, they talk about knowledge, and they talk about assumptions. So these sort of areas are more devastating to the women, affecting their satisfaction levels. I'll just stop for a second so that you have time to read that. Moving on to the next slide. I don't want to just say that it's all negative. Some of the work which is cited by the 2 studies, birth rights and 5 times more, including the ones that I've been involved, including my PhD study, and including other studies that are looking at experiences are good. They talk about how communication helps them. They talk about how kindness and compassion helps them. They talk about personalized, culturally safe care, and they talk about relationships. In my studies, in my work, which is both in practice and research and education, I think relationships are a glue to everything. I've seen, in my study, I did observational study, so I observed women when they were in labor in the maternity units, and some of the women who could not speak English. My study involved actually Pakistani Muslim women. Some of the women who couldn't speak English, they had a really wonderful experience because their midwife interacted with them. I can, think about one particular incident where this woman were newly migrated from Pakistan. She couldn't speak English, but her midwife, the way she engaged with that mother when she was having pain and she was distressed, the midwife put her hands on her thighs, looked into her eyes, and that is something that was so phenomenal, how she engaged with the mother. But we hear of other experiences where other studies have reported, I don't know whether I've used that excerpt here, where when women have touched the midwives to get support, the midwives have shunned their hand off and said, don't touch me. So they are, balancing, but good care as well. So the way I tried to look at what was happening, by using essentializing explanations, which involves more overgeneralizations about things such as culture, race, location, and so on and so forth. And in my study, and I've seen in other studies that have undertaken by midwives, that midwives drew on essential explanations that highlighted women's lack of ability to follow instructions, take responsibility for their care, and be proactive and be good clients. These women, the midwife said, do get the same care as every other woman gets. Where they fall down is when they do not go to the antenatal classes, and then they're not informed about the pain relief and do not want to have, So again, it's about the culture that's a problem. And the second, there, all Pakistani women get the same care that every woman gets on this delivery suite, but they do not go to the parentcraft classes, and they tend to learn from their mother-in-laws. So again, it is the culture that's a problem, and not the NHS. And similar findings from a recent study. A woman was told that her epidural had failed due to the anesthetic having to work harder in Black women because they have a bigger curvature at the bottom of their spines. One midwife, when doing the membrane sweep, that's an intervention what midwives do to sweep the membranes when they do the vaginal examination, said that the reason for dilatation taking so long for me was probably due to an African pelvis. Even though I was on pain relief, I was mortified that she actually believed there was such a thing as African pelvis. So here is another excerpt from a Pakistani woman, but I'll let you read it. So this is just, again, for me, thinks about woman not being able to interact with the midwife. The midwife does what needs to be doing on the job, gets the job done, but there's nothing extra there. Then there are racialized explanations coming from these studies, where midwives make reference to white or Caucasian women, particularly making reference to normal and accepted practices, that they rarely made a reference to race when they referred to Black, or when referring to minority women. And what we are currently seeing is that there are racial microaggressions, stereotypes, or assumptions. And I, in line with these authors, argue that really these are some of the key components, because very early on, and certainly the study that I did with Higginbottom, things about utilization of services came up as a theme as well. But we're seeing whilst communication and linguistic issues are a problem, or a challenge or a barrier. But I think we need to really think about that. Some of the women who are experiencing microaggressions speak English, are in very high-flying jobs. By that I mean they are educated, they can articulate, they can navigate their business, but they have problems navigating through the NHS. So here, 2007 describe microaggressions. They say this is everyday verbal, non-verbal, and environmental slights, snubs, or insult, whether these are intentional or unintentional, which communicate hostility, derogatory, or negative racial insults towards people of color. Although racial aggressions may not always be consciously racist, they show a thoughtlessness of other races, cultures, and identities, and often center the white perspective as a norm. For example, failing to learn the correct pronunciation of someone's name. Repeated exposure to aggressions compounds, trauma and harm, and there is evidence which is demonstrating that. And certainly in our study, we found that discrimination in maternity care services mitigates the delivery of good quality maternity care, because when maternity service users experience microaggressions, they really close. They do not want to interact with the midwives. So arguably, either the system or the professional silence the women with their attitudes and behaviors. The discrimination was often very subtle and difficult to specify, but direct and blatant discrimination was also documented in some cases. Subtle discrimination, including the staff responding to women's questions or requests in a rigid and often inappropriate manner. Evidence from one study reports that immigrant women were often not welcomed or greeted in a friendly manner and not made to feel safe. So Birthrights talks about this having a psychological safe space. Some women suffered acute negative feelings when they were treated differently by maternity care staff, and direct discrimination included healthcare staff uttering stereotypical and racist comments. And again, citing some of the testimonies of women, I take this from McLeish's study, which were to do with the asylum seekers. I'll let you read that. So this is again an example where the woman got very distressed. Second excerpt is from 5 Times More study. This talks about the midwife said in a mocking manner moments after I gave birth, "We will see you here next year again." Do you know, this is not something new. I looked at some work that were back in 1990s, Phoenix's work. I looked at Labe's work that were in 1988, and all those studies have similar things in them, where women were saying, well, you breed like rabbits, and those things are still coming again. So what is happening? The third one, you can sort of see there as well, not having an understanding of the sickle cell, and when the infection stuff started, there were sickle cell crisis that affected. So these are some examples, and certainly the Embrace 2020 report, when they were looking at microaggressions, they reported that there were constellation of biases that they could see within their, the cases that are referred to them, which may have contributed to, women's experience and, of course, deaths, because these are the cases that they examine. Then the other concept that I just want to touch very quickly is that is being othered. Women's experience of negative interactions, stereotypes, disrespect, discrimination, and cultural insensitivity. System-level factors as well as attitudes, knowledge, and behavior of healthcare staff contribute to some ethnic minority women feeling othered, unwelcome, and poorly cared for. Others, the concept of other is that who and what others are is intimately related to our own notion of who we are. So when you see the language that we're using, we, in our culture, we do this, but it's those women, they didn't do that. Those women don't go to, to the parent classes. Those women have got a chip on their shoulder. They are aggressive. So that separates this, it's me and them. That's the concept there. And I just feel, just to explain what othered means, these microaggressions, I've drawn upon this poem by somebody called Andrea Koch. I'll let you read it. Can I progress? So if I move on to my next slide, I'm just going to rush through these slides because I'm conscious that the time now is 1:15, and I just want to have about 10 minutes to, have a discussion. So what do Black women need? When you can see from this slide, the needs are no different to any woman in childbirth. So they want to be put first, they want caring and humane attitude, and they want accessible care that's easy, timely, and convenient. And of course, like everybody else, they want high quality services. So the needs aren't different. But what causes a challenge is that women say, and studies talk about, that many of these women are invisible, which leads to some of those problems. So what needs to be done? Clearly, there is still a lot of room to improve access and tailor maternity services to the needs of local population. And we need to harness the NHS pledges and the priorities which are being offered in their policy document, Equity and Equality, which was published in 2021. I think we need to have different kind of leadership. We need to really look at cultural intelligence and inclusive leadership, because we need a paradigm shift in an organization, and evidence demonstrate engagement and involvement with women and groups who use maternity services. This is the reference that I'm making to equity and equality, which I'm sure you're familiar with. And within this, there are 4 pledges for maternity services, which again I'm going to skip, but what birthrights categorizes racism, and I think that's what we really need to look at. It categorizes racism in 4 levels, and I think these are, and they are offering what needs to be done. And so the trick there is really about how do we translate this into maternity services, and how do we prioritize this given the context that I've talked earlier on. So I'm going to move on. This study is available online, and I've taken this from study page 4, and you can have a look at it later. I want to then look at how can we move towards anti-discriminatory care. We really need to look at what is done, what is there, you know, how can we make use of these areas and develop studies like care around those and use those. But often, you know, for example, we look at NICE, we look at RCOG guidelines, national guidelines. Not many, you know, refer to women from Black and Asian communities. Although, having said it, NICE, when they've updated their antenatal guidance 2021, have included ethnicity in it. So we, you know, we need to move towards that. And then we really need to look at what we're doing. And I think rather than beating ourselves up, I think we really need to look at what works well in an organization and use those frameworks to look at what does good look like. Don't let's focus on bad or poor experience. What does good look like? Let's do the good. And that should improve services. And certainly there are framework models around those areas. And outcomes clearly improved quality of care and clinical status and positive patient experience and satisfaction. Very quickly, I think we do need to focus around having, you know, diverse staff. And I know I've taken this from clearly public sector, private public sector in businesses, but NHS can extrapolate some of these things as well, that having diverse workforce really benefits its customers, it benefits the business. And I know I'm talking about business, and I know arguably people will say NHS isn't a business, but really, if we look at it, it is. Our customers, our service users, our customers, we as the people working in the NHS need to be satisfied of what we're doing, and that's the way we can give more. And so we need to you know, harness those as well. You know, I'm not going to go on them, but emerging issues really, I'm towards conclusion now, from these studies are that there's variable experiences of women during their encounters with maternity services, but majority value maternity services because they value Western healthcare. And we are an envy of a lot of countries. And also the women believe that doctors and midwives know the best. And hence, I think these women who speak English put a lot of trust in midwives and doctors. Many women are passive and silent partners, but many are informed, silent, compliant. And some did not, you know, engage with the services to determine their care because they get just so fed up. And in conclusion, Black women do not have unique needs during childbirth. However, what's disturbing and profoundly disturbing is that their needs continue to be unmet. For Black women, little has changed. Like I've seen studies that I used to use in my teaching session back in 1988, and when I was going to put pictures of them, but I just thought, there's so many slides. I want questions answered. I'm really struggling even to leave 5 minutes at the end of this, but I see the same things. So that's really upsetting that despite a lot of changes within the NHS, within the maternal services, experiences and outcomes are worrying. But I think race is an important marker in that experiences, clinical outcomes of Black women are significantly worse than their white counterparts. And I think staff in particular experience double whammy. They experience racism and discrimination. I haven't touched on that, but there is a wealth of literature out there which is talking about how staff from Black and minority ethnic communities feature within the NHS and in HEIs and in education sector as well. So it's not just saying NHS only, but it's wide, and then they're expected to fix it. So with that, I conclude. It just leaves us 5 minutes to have a discussion.
Thank you so much. If you could stop, that's great. And if people want to put the cameras on for the last 5 minutes, and if anyone's got any questions, but I thank you so much. That was really interesting, and it does sadden me that women are still experiencing what you've described they're experiencing. And one of the things that I'll take from this talk is about how we can make sure, Hearing Gate said, that we deliver an anti-discriminatory care across all of our services. And that is our ultimate goal for me. And so I found that really, really interesting, and certainly confirms some of the things that we are doing with our staff and with our communities is having that positive impact on the patients that we care for. So thank you so much. And I can see Leslie has her hand up. So Leslie,
you're
on mute still.
If you just say what your background is, just so that I can.
Can you hear me now?
Yes.
I'll turn the speakers on. Can you hear? Is that better?
Yes, yeah.
Kuldip, I'm head of midwifery, Gate said, head of midwifery and special care. So all you talk to is really, I echo everything that you said. And part of our agenda and midwifery strategy, and it's wider than midwives, as you rightly say, it's not just midwives, it's the whole team that often these mothers come into contact with, because often they are high risk and often they've got multifactorial health, mental health needs. So it's the wider team. So we are working really hard. And one of the things we're working on is around the delivery of more continuity of care. So it's smaller teams and focused teams on women in ethnic minorities. And also, I very much welcome that what you said is that all women deserve the basic needs that you've put, that every woman should be deserved to be treated with: competency, qualified staff, educated staff, kindness, dignity, all of that. Our list goes endless. But the ethnic moms do have the high, the population where there is increased need. So if the team on here aren't aware, we are doing a huge work in maternity services through better births. It is taking a while, through continuity of care. And also what's been key is that the ask for all of these mothers, even if you have a smaller caseload, you need more time to do this. So midwifery, community midwives especially, and antenatal clinics have really been restrained in these 15-minute slots, regardless of need or what any mother requires. So it's very much trying to spread everybody really thin. So there's a recognition that has to be taken nationally, regionally and trust-wide that the current models of you know, and staffing and whole-time equivalents that we've got out to do this work is not enough. We have to build in the increased capacity by increasing midwives. It's not just about increasing midwives, it's making sure that the student midwives who are coming into our professions share that philosophy, are there to challenge the old cultures that were there, because it is a culture it takes many years to break, and big challenges have got big memories, so often that is hard to break as well. But you have my assurance as a head of midwifery, as long as I am head of midwifery here, that we are focused in on that. We're focused in on this. We have a huge Jewish population which has diverse needs as well. But my ask to the trust, which I have been asking, and in my staffing requests, is that we cannot work the way that we've always worked, or we'll always get what we've always got. We have to work differently, and that includes increasing time for mothers at every contact to make sure that we understand. One of the big problems I will raise here, and Jane knows, and I think the trusts do know, we have huge problems with interpreting services, you know, getting them as we need. You know, we would be so much slicker and quicker and better if we had better access to that. And I know that's a national and regional problem, but I think that is one of the things that we have to work hard on. But I guess it's about challenging cultures. But I'm committed to making sure that we make a difference as we speak, and I know we are trying hard, but it will not happen overnight. But the commitment's there, and I'm so sorry. The state I'm on my annual leave. I'm looking after a toddler. He's running me ragged. I've just put him to bed, so I need a cup of tea. But you have my absolute commitment. And the teams, I know the midwives and obstetricians who have just come off a regional call about East Kent and the care and compassion. It's not just about clinical competence. I think I echo that right the way through. We've got to work a lot harder and work on civility, kindness, compassion, and individual needs of mothers, regardless of ethnicity. But commitments there, I promise, and
That's
from
excellent.
everybody.
Thank you, Leslie. That's fabulous.
And just in terms of, you know, stop responding to that, I think this is what I was trying to say, that nobody tried to give a service and nobody wants to come to give bad care. Nobody wants that. But we really need to understand the context. And I think you've touched on two things which are very dear to me. One is relationship with the women are very important, and I've seen that when you develop a relationship with a woman, you can communicate with them. You don't always need words, they help, but they are. So we have continuity of care model, but what's happened at national level, funding is not there now, and there's been a U-turn.
It's been set to fail. It was set to fail at the beginning because the resources weren't put in, but we're working hard to rectify that, and I'm sure that we've got more focus on what we can do to make it better.
Great. So I'm conscious of the time because we've just gone past the 1:30. But has anyone got any other comments or questions they want to ask? I can't see any hands up. If everyone's okay, we have been recording this so that we can share it with other staff who weren't able to come on today. So Kuldip, are you okay with that we share this recording with our teams and wider in the organisation? But I found that exceptional, and it's really given me some food for thought. And Leslie, you have, as you know, our full support with supporting you and your teams in maternity around this. But also I think it's that anti-discriminatory care across all our services is what we're ultimately striving for here in Gateshead. So thank you so much for the session today, and I'll close the session.
Thank you very much. And
Thank
you've got
you.
my email address. If anybody wants something, please do email me. Thank you.
Great. Thank you
Thank
very
you.
much. You get some
Thank
rounds
you.
of applause there.
Thank you. Thank you. It's been a delight. Thank you.
Thank you very much. Take care,
Thank you.
everybody.
Thank you. Bye.
Bye.